So we move to the fourth session today about quitting tobacco and nicotine products. As you've seen, we pick up different topics on tobacco control during the symposium today. We usually have it like monographic one topic, but this year we wanted to make it covering different areas of tobacco control. And the next session is about cessation, and it will be moderated by Elizaveta Lebedeva from the Tobacco Control Unit at the European Regional Office for WHO.
Yeah. Thank you so much, Alena, and thank you everyone for staying with us for this session. So it will focus on another essential component of the comprehensive tobacco control on helping tobacco users quit. So we know that 60% globally, over 60% of the world's 1.25 billion tobacco users want to quit, with many of them saying that they regret they have even started doing this. Yet two-thirds of these people lack access to effective cessation due to various reasons, including health system challenges such as resource constraints. So in our region, in the European region, we have 179 million tobacco users. And only 11 countries out of 53 currently provide best practice level support for treatment of tobacco dependence. So it is clear that more should be done, more must be done to support communities and governments to provide this essential support to people wanting to overcome this addiction. So in this in mind, we will be focusing on two key topics in this session. First is the latest technical guidance on tobacco cessation, and the second topic is how implementation science can improve the coverage, reach, and quality of cessation programs. And we have excellent panel of experts with us. And as before, we will do the presentation first and then have a Q&A session. So our first speaker is Dr. Dongbo, a medical officer for tobacco cessation in WHO No Tobacco Unit. And Dr. Fu has over 15 years of international and in-country experience in tobacco cessation and treatment of tobacco dependence. And he leads WHO's technical work in this area, and also, notably, he coordinated the development of the newly published WHO clinical treatment guideline, which will be the focus of his presentation. So Dongbo, the floor is yours.
Great. Thank you, Lisa, for your nice. Okay, good afternoon, everyone. So it's my pleasure to be invited to attend this symposium. Just want to say I'm really happy to come back because I think a couple years ago I attended this symposium, and it's very nice to be back again. I was asked to give a presentation on WHO clinical treatment guideline for tobacco cessation in adults. In other words, I'd like to share with you what are WHO recommended tobacco cessation interventions for adult tobacco users. So my presentation will cover three major things. First, we'll introduce what are the WHO standard guideline development process and methods, which really can help to understand why this is a little bit different or have unique components. And then second, what's the objective of this guideline? Lastly, mainly focus on, give you a summary of the guideline recommendations. So on the 2nd of July this year, WHO released its first ever clinical treatment guideline for tobacco cessation in adults. You probably never, many people never believe this is just the first one because we heard lots of work done by WHO, but until this year, we were able to have the first clinical treatment guideline. The guideline was developed following WHO standard process and methods as described in WHO Handbook for Guideline Development. And our department is a health promotion department, oversaw the guideline development process, and together with a dedicated WHO steering group and methodologist and also a guideline development group. So I would also like to take this opportunity to thank WHO experts and also external experts who made a great contribution to this guideline development. For example, Angela from Euro served as a member of the WHO steering group, and Corel and her team helped us as a systematic review team. So thank you very much for helping WHO to accomplish this great guideline. And of course, as a WHO guideline, the whole guideline development process was closely monitored by WHO guideline review committees. The committee really to make sure the WHO regulations, standards, and values are applied into the guideline. So that's the process. Then the objective of this guideline is really to provide a comprehensive set of global technical guidance for WHO member states to provide support to 1.25 billion adult tobacco users to quit by using evidence-based behavior interventions and also pharmacological treatments as a comprehensive tobacco control approach at the country level. So the guideline contains totally 12 recommendations for 7 categories of interventions, which are behavior support delivered in clinical and community settings, digital tobacco cessation interventions, pharmacological interventions, interventions for smokeless tobacco use cessation, combination of behavior and pharmacological treatments, traditional, complementary, and alternative therapies. And the last one is a system-level interventions and policies. So I'm going to go over the recommendation for each of the 7 categories. Let's start with the first category. Here, have to make sure the behavior support is defined as a support other than medications aimed at helping people stop their tobacco use by improving their knowledge, skills, and strategies. So in our guideline, the behavior support includes behavior brief intervention and also intensive behavior support, which consists of, we see here is more like the features, multiple sessions of individual, group, or telephone counseling. That's the behavior support which we mean. And there are 2 recommendations you can find in this guideline for this category. First, the WHO recommends brief advice, covering like between 30 seconds and 3 minutes per encounter, be consistently provided by all healthcare professionals as a routine practice to all tobacco users. Doesn't matter the person is ready to quit or not, is interested in quit or not. We need to provide this advice to all of them, accessing any healthcare settings. So this is a strong recommendation based on the moderate certainty of evidence. The second recommendation is WHO recommends more intensive behavior support be offered to all tobacco users who are interested in quitting. So there's a difference. The intensive behavior support is offered to those who are interested in quitting. The options for behavior support can be individual face-to-face counseling, or group face-to-face counseling, or telephone counseling. And we emphasize multiple behavior support options should be provided. So this is also a strong recommendation based on the high certainty of evidence for individual counseling and the moderate certainty of evidence for group counseling and telephone counseling. For the second category, in terms of digital tobacco cessation interventions, here also need to emphasize, here the digital tobacco cessation intervention is defined as the interventions provided through digital technologies can involve the following 4 modalities, which are text messaging, internet-based interventions, smartphone applications, and artificial intelligence-based software interventions. So the recommendation which we made is really focused on these 4 modalities. So WHO recommends digital tobacco cessation modalities, which we just mentioned, the 4 modalities, individually or combined, can be made available for tobacco users interested in quitting either as an adjunct to other proven tobacco cessation support or as a self-management tool. So this is a conditional recommendation, mainly because the certainty of evidence for some are still low or very low. So it's based on the moderate certainty of evidence only for text messaging. And then for the other three modalities, we have low or very low certainty of evidence. Okay, for pharmaco interventions, we also have two recommendations. First, the WHO recommends varenicline, nicotine replacement therapy, we call NRT, bupropion, and cytosine as pharmacological treatment options for tobacco users who smoke and are interested in quitting. Among them, varenicline, NRT, and bupropion are recommended as first-line options. For those tobacco users who are interested in using NRT to quit, WHO recommends them to use combination NRT over the NRT monotherapy. So this is a strong recommendation based on the high certainty or moderate certainty of evidence. The second recommendation is on the combination of different medication. WHO recommends bupropion in combination with NRT or varenicline should be offered to tobacco users interested in quitting when there's inadequate response to the first-line options, which we just mentioned. This is also a conditional recommendation based on the moderate certainty or low certainty of evidence. For the smokeless tobacco use cessation, we also have two recommendations. The first one, WHO recommends the previously mentioned intensive behavior support, which include individual face-to-face counseling, group face-to-face counseling, or telephone counseling, should be provided for smokeless tobacco users who are interested in quitting as well. This is a strong recommendation based on the moderate certainty of evidence. WHO recommends varenicline or NRT to be used as pharmacological option for smokeless tobacco users who are interested in quitting. This is also a strong recommendation based on moderate certainty of evidence or low certainty of evidence. In terms of combination of behavior and pharmacological treatments, WHO recommends we should combine pharmacotherapy and behavior intervention to support tobacco's interest in quitting. So this is a strong recommendation based on high certainty of evidence. In other words, if we really concern the success of quitting, this is a recommendation we need to implement. For the traditional, complementary, and the alternative therapies for tobacco cessation, no recommendation has been made by the guideline development group. They provided a statement. The statement is evidence is insufficient to make a recommendation for or against traditional, complementary, and alternative therapies for tobacco cessation. If these therapies are utilized by tobacco users interested in quitting, we suggest we need to ensure they are offered as a comprehensive approach to support tobacco cessation. In other words, they shouldn't be offered standalone as a standalone intervention for tobacco cessation. They should be offered together with other proven behavior support or pharmacotherapy. That is a statement for traditional, complementary, and alternative therapies. And the last category is the system-level interventions and policies. These are really for policymakers and service managers for them to promote proven tobacco cessation interventions. WHO made 3 recommendations for this category. First, WHO recommends all healthcare facilities should include tobacco use status and the use of tobacco cessation intervention in their medical records, including electronic health records, to facilitate the provider interaction with tobacco using patients and to increase adoption and maintenance of evidence-based tobacco cessation interventions. This is a strong recommendation based on the moderate certainty of evidence. Second recommendation WHO made is we should train all healthcare providers on delivery of evidence-based cessation interventions, together with ongoing prompting and feedback in their routine medical practices at all levels of healthcare setting. This is also a strong recommendation based on moderate certainty of evidence. The final recommendation, WHO recommends that evidence-based tobacco cessation interventions be provided at no or reduced cost to all tobacco users interested in quitting. No cost is strongly preferred over reduced cost. So this is also a strong recommendation based on the moderate certainty of evidence. So I want to stop here and looking forward to any question about our recommended cessation intervention. We also took a few hard copies of this guideline. So if you are interested, feel free to pick one. Thank you so much.
Thank you so much, Dongbo, for outlining the recommendations. And colleagues, it's vital that we continue to encourage providers and policymakers and stakeholders to adopt, adapt, and implement these recommendations. So our next speaker is Cristina Martínez, whom many of you know well. So Cristina is a senior researcher, expert in tobacco control. She is also acting head of the tobacco control unit here at ICO and assistant professor at the University of Barcelona. And Cristina, her work focuses on evaluating tobacco control policies in healthcare services with a particular emphasis on smoking cessation. So Cristina will be talking today about implementation science in the context of tobacco cessation. So please.
So thank you very much, Lisa, and thank you very much, Dongbo, because you have introduced the WHO guidelines in smoking cessation. I want a copy. One copy is for me, okay? So you bring the topic of the guideline, and this serves me as a foundation to talk about the topic I want to explain today, that is how implementation science serves and helps to transfer smoking cessation into practice. This is where implementation really excels. It provides a structured, evidence-based framework to close the persistent gap between what we know and what we do. What implementation science provides is a focus on how to improve the implementation, but it can be applied not only in smoking cessation, it can be applied to other applications through the tobacco control. But today my focus is going to be in the role of enhancing smoking cessation services within healthcare services. Over the few minutes, I will walk through the core principles of implementation science, trying to illustrate how to empower and transform the ideas into lasting, impactful change. So this is more or less the questions that I'm going to address. I'm going to try to answer the questions of what is implementation science, what is implementation science and how can it improve smoking cessation services. I will also highlight key strategies in primary care and hospitals, and also how strategies can expand and sustain these efforts in the time. So after my summary and the main remarks, we will open the floor for your questions, comments, and hopefully for your insights in your experience implementing implementation science in the field, or probably no. So let's start. So efficacy studies and effectiveness studies evaluate what it works, while systematic reviews and meta-analysis summarize the evidence and tell us what interventions are more recommended. These findings are all synthesized in guidelines like this one that we have today here, the WHO released it the day of my birthday, by the way, okay, this is something significant. So this guideline will help us to move and transfer what we know into the practice. But currently, we know that according to the guidelines, what we know, and already Dongbo has mentioned, is that behavioral therapy, pharmacological support, and also follow-up to prevent relapse has a strong evidence. This kind of combined intervention can be delivered using the 5 A's models. Of course, We know that this is the reality, and even the WHO has recommended not only the guidelines, but also that all health professionals incorporate these guidelines into practice. Like this, we will introduce one of the policies included in Empower, that is offer. However, the reality is quite different and clearly different from what expected, because as you can see in this slide, according to a review conducted among primary care physicians in 17 countries, we found that the average implementation of the 5 A's is less than optimum. In the case of receiving access, 36% of patients received access, and only 22 were arranged a follow-up. This is the case for primary care. In the case of hospitals, in a study that we conducted here in Barcelona years ago, we asked patients about the level of receipt of smoking cessation during their hospitalization. And we saw that 60% of hospitalized patients who were smokers were asked about their smoking consumption, and only 5% received the 5 8 components of the 5 8 model. So this is, as I have mentioned, far from optimal. So the barriers of implementation of smoking cessation in healthcare services have been studied, and one of the main is the lack of training of health professionals. 75% of health professionals, when they finish their degree, either nursing, pharmacy, medicine, and so on, 75% say that they have not received any kind of smoking cessation training during their degree. This is one of the main constraints, but we have other constraints, like, for instance, the lack of time. Health professionals, they don't have time to provide smoking cessation during their consultations, the lack of protocols during their, in the organizations that they are working, and also the exclusion of these activities or roles in their portfolio service. So in order to reduce the gap between what we know and what we do, implementation science is a kind of solution, not only for smoking cessation, but for other kind of evidence-based practices. We know that there is a gap between 17 years gaps between research and application, and only 14% of original research has been translated to patient benefit. So implementation science, which studies the methods to promote the adoption, the implementation, and the sustainability of evidence-based practice, could help in the process of transferring knowledge to practice. The foundation of implementation science is that it continues the pipeline of research that starts in the discovering of the science in the preclinical studies, but continues to other phases that reach also the patient and the community. Here at T3 and T4 is when really implementation science makes sense, and because are the tougher part of the transferring knowledge to practice. This science, it originated years ago in the 80s and 90s and was formalized by the combination of different interdisciplinary fields, including public health, health service research, and behavioral science. And it combines different knowledge and methodologies to improve the uptake of practices in the real world. In order to explain implementation science, it is necessary to explain some of their concepts that are quite distinct from the other sciences. So here we have several concepts. We are going to start with the intervention, that can be called also the thing according to Geoffrey Curran. And here the thing is our guidelines, the WHO guidelines, that contains not only the 5 A's model, but also the behavioral approach and the pharmacological approach. So this is the intervention, the thing that we want to implement. Then we have the determinants that act as barriers and facilitators to successfully implement, and often are categorized across different levels, individual or contextual. Next, we can focus on the strategies, implementation strategies that are the how. These are the tools and processes we use to integrate the intervention to real-world settings, tailored to address specific barriers and contexts. And then we have implementation outcomes, like adoption, fidelity, and acceptability. These outcomes are different from health outcomes, and these outcomes belong about the results that the implementation strategies have provoked after their implementation or after their application. So we were saying that implementation strategies are the how. These are the tools and processes that are not chosen randomly. They are chosen carefully selected based on the needs and the barriers identified in each context. During the assessment phase, we discover what are the main barriers and facilitators that can be unique to each context and each group of individuals. And like this, we are able to set from a variety of strategies which one fits better to our project. We were saying that there are several implementation strategies. In fact, according to the study ERIC, they have been identified over 73 different implementation strategies that have been categorized in 9 domains. We have here several of them, including, for instance, training. That is one of the most used in the literature. But not only, we have also evaluation and iterative strategies that include audits or monitoring tools. We have also adaptation and tailored context strategies, also support to clinicians, like creating growth floors and resources, to remember the fact that they need to do this kind of intervention, or we have also even financial strategies. These implementation strategies produce outcomes that, as I have mentioned before, are different from health outcomes and provide the information about how successful the implementation strategies have been. These implementation outcomes have been classified in also 9 different categories. According to Proto framework, we have acceptability, adoption, appropriateness, feasibility, fidelity, penetration, sustainability, and cost. As you can see here in this slide, acceptability and adoption belong better to the initial part of a project when you are measuring the initial use. Fidelity, it belongs better to the center part of the intervention when the implementation of something has been taking place, and we want to know how well has been delivered according to the intended. And other outcomes that are in the last part of the ladder, like sustainability, cost, focus more on the long-term delivery. But in addition to these concepts, we need to also to highlight that in implementation science, there are several models, theories, and frameworks. Indeed, they have been identified over 140 models in the literature. Not all belong to implementation science. They belong to several sciences, like behavioral sciences, like health policy science, and so on. But Nielsen categorized them in 5 different categories. Those that are important for process models that guide the implementation process, determinant frameworks that identify the factors influencing implementation, classical theories that explore behaviors and phenomena, implementation theories to provide implementation-specific explanations, and evaluation frameworks that help us to evaluate the outcomes and its impact. So how can we use, now that we have defined the concepts and the theories, or more or less say that there are theories and models and frameworks, how can we use implementation science for improving smoking cessation? Well, I have said before that implementation science offers a structured approach to bridge the evidence-based gap, and it can be used for identifying first barriers and facilitators, also to analyze contextual, individual, or organizational factors that hinder the adoption. In addition, it can be used for adapting existing programs that have been tested in previous studies to our reality in a more effectiveness layout. It can also be used to design and tailor strategies according to the context, and also to measure implementation outcomes that I have defined before. So let's start with the first part, that is, I'm going to condense the 2 first purposes in just one comment. So how can we use implementation science for identifying barriers and analyzing the context? There are many models in the literature that can help us, but I'm going to highlight the two that have been highly used. The Consolidated Framework for Implementation Research, also called CIFR, and the Theoretical Domains Framework, TDF. These two models have been used to identify barriers and facilitators, not only in smoking cessation, but they can help us to understand better some of the elements that include, that describe the situation of the intervention, how the intervention is, how the outer setting is, how the inner setting is, and what are the characteristics of the individuals in the case of the consolidated framework. Also, it helps us to understand the process of planning and executing. We have also another model that is the TDF that focuses more at the behavioral change level. It contains 14 domains and includes knowledge, skills, social and professional role, environmental context, and others. This one has been mainly used for addressing behavioral barriers in healthcare providers and patients. Both of them help us to identify the determinants of successful implementation and inform us how to tailor strategies to overcome the barriers and leveraging the facilitators. In the literature, we can find some papers, some literature that have used these models before, not many, so we still need more research that can use this approach, theory-oriented, analysis-driven research approach, in order to understand better the context, and then select the better strategies according to the situation. This is important because bear in mind that every group of individuals are different and every context is different. Another way that we can use implementation science in smoking cessation or in trying to improve the level of implementation of smoking cessation is by adapting existing programs to our reality. Adapting a smoking cessation intervention ensures that something that has been tested before and has demonstrated that its efficacy can be transferred to another context, saving time and money. We have different adaptation models in the literature. For instance, we have FRAME, DAP, IAM-ADAPT. And for instance, this is the case of one of the projects that we are using IAM-ADAPT for adapting this smoke-free homes project that Emory has developed in our context. This is not an example of a smoking cessation, but it's an example of how to adapt an intervention that has been proven efficacy in other contexts, even in a trial, and then transfer it in an effectiveness way in a different context. We also can design and tailor strategies and measuring implementation outcomes by using implementation science. In fact, there are 2 reviews in the literature that review what strategies are more successful in order to implement a smoking cessation. The first one is in primary care, and the second one is in hospitals. The first one, it was released in 2023, and it says that financial strategies, changing the infrastructure and recording systems, improve the training, and engage consumers, increase the adoption of a smoking status, recording the smoking status of patients, and also increasing the level of advice that health providers provide to smokers. This means that the 2 A's are more implemented after undertaking these 2 strategies. In the case of hospitals, another review released in 2022 says that strategies that are predominantly focused on the staff, on training staff, and 7 implementation strategies groups, strategies predominantly focused on staff training. This is what normally is done in the literature. But they have classified even up to 7 implementation strategy groups that go from brief external-led training to internal-led system changes that is more intense. So they have seen that they have, there is limited adoption and sustainability when we have brief external-led training versus when we have internal-led system changes that increase the feasibility and the penetration. These internal-led system changes include stakeholder engagement. That means that they select a champion. They have frontline staff trained and also with the responsibility of implementing interventions. They create monitoring and reinforcement activities like auditing and reporting data about how they are doing with the intervention. Planning and organization systems, electronic streamlined workflows, and also, of course, training that doesn't go is isolated. It goes in combination with the other strategies. This can be said that is a system-level approach at the organizational level that assures the assessment, treatment, and referral of the patient who is a smoker at the hospital care. So we can say that the implementation strategies that are efficacy at the healthcare services are training, of course, but also planning and organizing, changing the system design or changing the system of care, and also giving monitoring and feedback. By using these strategies, we increase the adoption, we enhance the acceptability of both the staff and the patients, but it is true that without resources and with a high workload, we threaten the feasibility. Also, it's important that these strategies are not one-day effort. Instead of one-day effort, what is recommended is a long-term support of structures that improve the sustainability and the penetration. That means to create a system-level approach. This system-level approach is what the latest guidelines of WHO has included. In fact, is what Dongbo has already included before in his presentation. And this is something that really highlights the importance of how to embed this smoking cessation at the organizational levels. From the best of my knowledge, the two international projects that include these health system level interventions are the Ottawa Model and the Global Network for Tobacco-Free Health Care Services. One has been mainly used in primary care, but also in hospitals, and it was created in the 90s in Canada and has been spread international. The other, it started with an European project, but now it has become more international. It stands in 8 different standards, and also it has a kind of movement, global movement, in which different organizations give the support between one and the others. We have said that implementing strategies, we can see after implementing strategies what are the implementation outcomes, but in these projects, not only they have implemented the implementation outcomes, they have implemented, in the case of the Ottawa Model, the implementation the results outcomes. The results outcomes in terms of health of the patients. We can see in this figure how comparing hospitals that have implemented fully the intervention, the smoking cessation intervention, embedded in the of the hospital, they have reduced the level of mortality for all the causes of the patients and also the readmission of the hospital rates. But of course, these kind of policies at the hospital level cannot be alone. They need to be supported by the national and regional health policy, asking hospitals and health systems for accreditations, standards about professional standards, even provide hospitals like some kind of regulations, and also provide them like the possibility of training materials, campaigns, or even the reimbursement of some smoking cessation help, or even free, of course, why not, okay? So, in conclusion, we can say that implementation science bridges the gap between what we know and what we do by identifying the barriers and facilitators, by tailoring adapting solutions, by implementing strategies that really are fit to the determinants that we have selected, by improving the implementation outcomes, and in the long run, the ultimate goal, the ultimate result is going to be promote the better health and outcomes. Of course, implementation science is not magic, but it produces wonderful results, And I think that is something that it can improve smoking cessation services in our context. Thank you very much for your attention.
Thank you so much, Cristina, for these valuable insights of how implementation science can transform tobacco cessation efforts, how to bridge this gap between evidence and practice, address barriers, and tailor strategies. So, colleagues, we have around 8 minutes if we want to be on schedule. I invite your comments, questions, or reflections for our speakers. Yes, Elizaveta. Thank you.
Thank you very much for both of you. Thank you, Dongbo and Cristina. Very nice talks, very illustrative. I have, I don't know whether it's a crazy question for Dongbo. Do you know which was the reaction of governments, scientific societies, and some sectors implicated in smoking and theoretically implicated in smoking cessation, such as vaping associations and so on? Because one of the first things I did when the report was released was to do Control F in the PDF, searching for electronic cigarettes. And well, it was not a surprise, but there was no term in the retrieve from the search. So reactions from these three kind of bodies, if available, or your impression?
Okay, great, thank you. I think according to my limited understanding about reaction, for the governments, we receive very positive response. Probably you remember the Article 14 guideline of the WHO-CDC recommend the national clinical treatment guideline is one of the basic infrastructure to promote tobacco cessation at country level. But according to our understanding, is only 60% of them have some sort of national treatment guideline, and the majority of them have not been updated for a long time. So we see quite a lot of requests from country, say we want to adapt or update our guideline based on WHO newly released clinical treatment guideline. So this is the work which we are planning to do in the early next year. And also for individuals, we already supported several countries to adapt their guideline based on our newly released guideline. I think this to me is very positive. And then for the one you mentioned, the vaping, or those who believe e-cigarettes is a way to help tobacco quit, we received some kind of comments that, oh, finally WHO doing something, but that's not enough. To me, there's a positive way, say at least WHO formally have some recommended proven intervention to help tobacco use quit. And they probably said, okay, you didn't include e-cigarettes as a solution, but that's already we discussed, right? This is very complicated, and the potential benefits and the harms of using e-cigarettes is in another category of literature or evidence, which is not our guide. It's not within the scope of our guideline. But we are also trying to say we will closely monitor the evidence. At some point, probably we'll decide to develop a similar guideline to address how to stop using these nicotine products, but really very much depending on the availability of evidence. That's our answer. Another group is, you mentioned which group? Scientific science. Yeah, for this one, in this guideline, we identified a list of priority research, what we call needed research needs. So we have a list of priority lists to say in which area, in which topic we need more research. I think this also, we got quite positive response, say many of the research team willing to come to see which gap they would like to support to fill. Give one example linking to the nicotine cessation. many research groups, they would like to see if there any research can help identify some effective interventions to help the e-cigarette users to stop using these products. And we see, give one example, the US Choose Initiative, I think they published RTC to report the text message intervention can help young people who using e-cigarette to stop, quit these products. Just give one example. And we have some research on whether using the quit line can help e-cigarette user to quit or not. I think there's some preliminary research. And then there are ongoing research. For example, I know the cytosine, that somebody is doing research to test whether cytosine can be used to helping the vapors to stop using these products or not. And also, Cristina mentioned the implementation science. I think we all agree the challenge is, according to the RCT, we know the interventions works very well, but at the end, if you look the reality or in the real world, the number of people actually use the intervention is very limited, I would say, compared to we have 1.25 billion tobacco users. Then we have to think about what things we can do to help increase, we call adoption or the reach of this intervention. I think this intervention also area is something we receive a quite positive response. Many research groups say they are in this process to help. Yeah, that's just in general quite positive, and also we also believe from outside it is something we could do much earlier, but we was only able to do it by July this year. Thank you.
Hello, Coral Gartner from the University of Queensland. This is probably a question for both speakers, Cristina and Dongbo, about funding the smoking cessation services so that it gets implemented. So I'm thinking in Australia, so the recommendation that the services are all offered for free, and in Australia we still charge the patients for pharmacotherapy. It's subsidised, but they still have to pay a co-payment. And yet we have like the most expensive cigarettes in the world because of the tax that's taken in. Is there any opportunity to advocate for funding through like earmarking tobacco tax? I'm just thinking some countries would be quite concerned about the cost of providing this cessation support.
Yeah, I think this, according to the recommendation, is very clear. If we provide free services to tobacco users who is going to quit, so you can see the adoption or the use of the services is much higher, and also they are more likely to quit successfully. But in reality, as we all know, many countries, for many reasons, they're not able to provide free services or even reduce the cost. From our side, in terms of helping the country, we try to see are there other opportunity for policy change we would promote. For example, in WHO we're promoting this kind of we call universal health coverage. They have this kind of beneficial package, or just a UHC package. In this policy change, if we include cessation inside, the cost will be covered. That's one way we are doing. Second, since we are thinking about, for example, in many countries, if the medication included into their national essential drug list, the cost or the way of supply will be much easier. So this is another policy which we are promoting as well. You could see in the last few years, WHO trying to add several proven medication to WHO model list essential medicine, basically to set an example, say, country, please follow, including this essential medicine into your national essential drug list. These are the two things which you are thinking about. But of course, each country have a different way to cover the cessation service cost. For example, some country will have like a special health program to cover. some use insurance, national or other private insurance. We're also trying to encourage them to do that. So that's what we are doing.
Thank you for the question. I'm going to talk not only about the medication, because medication has a cost. Of course, there are some countries, like is the case of Spain, that the treatment has been included in the list of treatments that are subsidized by the government. I mean, depending on your regime, you pay a bit or more, depending on your situation, okay? But this is the pharmacological aid. Then we have also the behavioral aid or the approach. I think that the smoking cessation is not only providing a smoking cessation aid, pharmacological aid, is also including the service in the patient journey. For instance, we are in a hospital that is only for cancer patients. This should be something embedded in the patient journey. It doesn't matter what kind of cancer this person has, or even it has not any cancer. So smoking cessation, in my point of view, is not only providing the intervention, it's also how to try to embed this intervention in the approach of this patient with a health provider. Whenever they go to the primary care, whenever they go to the hospital for only for a check or examination, or for the need of a treatment, whatever the treatment is, even not tobacco related. So this is the real challenge. The challenge is not the medication. Of course, in a hospital like this, where we are treating patients with cancer and they need chemo and radio and other kind of approaches that are very expensive, the amount of nicotine replacement therapy that you are spending, it's very low, so it cannot be compared. But the important thing is not the drug, it's the approach that you are giving to the patient. Because even we know all that something that we have not spoken, but being in front of a health professional, being hospitalized in a hospital is an opportunity to change and start to think about your behavior. And this is better when when you are surrounded by other tobacco control policies, when you are in a smoke-free society and there are smoke-free grounds, or they are in the hospital, or there are other policies that work together. So the cost of the pharmacological aid is something that is important, but the most important challenge is not to pay the medication, is to pay the health providers, train them to include these reminders, to include these workflow systems that make possible the intervention. But this is something that several hospitals, for instance, in the United States, the Joint Commission have required hospitals to have some standards. They need to comply with some standards in some cases. For instance, if you are treating cardiovascular patients or respiratory patients, all these patients need to be assessed, or connect to another service when they are discharged. So for me, the real challenge is not the medication, it's the provision of the intervention.
Yes, and one final question, if I may, because we've been talking about adult tobacco users, and that the guidelines, they focus on adults over 18 years old. And in our region, we have 4 million children aged 13, 15 years old who use tobacco. So, Dongbo, any insights on this? What interventions are effective for tobacco users under 18?
Okay, yeah. Now we have been asked by country as well. Say, how about people younger than 18 years old? Just want to say this is the first ever WHO clinical treatment guideline. So the steering group at that time had to decide how can we finish this job within the period of time, and also based on the resources we have. So at the end we decide, okay, for the first guideline, we will focus on helping those 1.25 billion adult tobacco users to stop using tobacco. So that's the scope we decide. Although in the guideline, we didn't make a specific recommendation for those who are younger than 18 years old to quit, but all the recommended behavior interventions, either breathwise, the intensive behavior support, the digital tobacco cessation interventions. All of these behavior intervention are also applied to people younger than 18 years old to stop using tobacco. So I would just say the behavior interventions are applied to people younger than 18 years to stop as well.
Thank you so much. So on this note, I think it's time to wrap up this session. So my appreciation to our speakers, Dongbo, Cristina, a round of applause, please. And also to you for your attention and very good questions. Thank you, everyone.